Hello, and thank you for joining me at the GHAPP MASLD and MASH Community Network. I hope you enjoy our presentation today, our case presentation on lifestyle management. My name is Robin Soto. I'm a nurse practitioner at UC San Diego Health. I work with patients who have clinical liver disease of all types in the ambulatory setting. If you would like to register for this meeting, please use this QR code. If you would like more information about Rezdiffra, please visit GHAPP MASLD MASH Community Network to view Madrigal MASH disease state education and Madrigal Rezdiffra promotional programs. So let's begin. Today we are here with Albert. He is a 65-year-old male with obesity. He's referred for elevated liver enzymes and an abnormal imaging with abdominal ultrasound remarkable for increased echogenicity that's consistent with steatosis. Albert is 65. He is Hispanic, male, and his BMI is 29. In our history, Albert reports no alcohol use since he was in his 20s. His past medical history includes type 2 diabetes, hypertension, and hyperlipidemia. His lab results include his triglycerides at 89, his HDL at 41, his hemoglobin A1C at 7.2, and ALT with known elevations for at least 3 years of 1 to 2 times the upper limit of normal. We've done the workup and the evaluation for other causes of chronic liver disease, and that all falls negative. On our exam, Albert has central abdominal adiposity. However, he has no stigmata of advanced liver disease, and reminding ourselves that his BMI is 29. So in this scenario, Albert has about every risk factor there is for fatty liver. He has type 2 diabetes, he has hypertension, he has hyperlipidemia, he may have some genetic predisposition to have fatty liver, and his weight is over the optimal weight or BMI of 25. And so the likely diagnosis, we're pretty sure in Albert, would be metabolic dysfunction-associated steatotic liver disease, or MASLD, or sometimes we just use the overarching term steatotic liver disease. So with his labs, what we're most interested in at this point, since we think that based on his imaging, his labs, his workup, his risk factors, that we have a case of metabolic dysfunction-associated steatohepatitis or steatotic liver disease. We can do some simple tests that are non-invasive to get a sense of, does he have fibrosis? So simply using the ALT value, the AST value, and his platelet count, along with his age, in his case, we can calculate what's called a FIB-4. His FIB-4 is 2.22. And in Albert's case, using this algorithm that we have made for working through diagnosis of MASLD and then trying to find out if we're at high risk, moderate risk, or low risk, Albert's FIB-4 finds itself in this middle range, which is indeterminate. And often clinically, we never really have a slam dunk. We never have a perfectly low risk or a perfectly high risk. So often we will have to work through some kind of gray area for his indeterminate risk. And so basically we see up here that for a primary care or anyone else who might be working with a MASLD patient, we certainly have already come up with his risk factors. So at least 2 of the risk factors, he has more than that, plus any imaging abnormalities that suggest steatosis or elevated ALT and AST. And then we work through the simple We restart.
Yeah, if you want to restart that slide, you can, and then we can edit it.
I'm sorry. I'll put
It's
it on
okay.
the airplane. I didn't even think of that, right?
Mm-hmm.
All right, so restart at this slide.
Yeah.
Or back, let me back out to the, I'll start describing the NITs, right? Right here?
Yep, that's perfect.
Okay. So after assessing Albert and coming up with the most likely diagnosis of MASLD, we now want to look into what level of damage or potential fibrosis or even cirrhosis that Albert might have. First, we are able to calculate some relatively, definitely non-invasive tests using the simple lab values that we already have. So using Albert's ALT and AST level and his platelet count, along with his age, we can calculate what's called a fibrosis-4 test, or a FIB-4. Albert's FIB-4 is 2.22. And so we do follow an algorithm to kind of make these things a little bit easier. And this is a nice one that we have made to help primary cares and other people outside the liver space, made it a little bit more clear on how to work through the diagnosis. So step one, we already identified his risk factors. He has more than two, and he also has the other requirements, which is either steatosis or elevated liver tests on exam. And then we work down to his non-invasive test. And so the non-invasive tests here, the levels for the FIB-4 are noted. And so as you see, his 2.22 puts him squarely in the indeterminate risk space, which is often how things work in clinic. We know that clinically there's never really a super clear answer on a high risk or a super clear answer on a low risk, but often we find these things sort of in the middle. And so at this point, what should we do next? So another option for our fibrosis measure is a FibroScan, or a vibratory controlled vibratory controlled stiffness measurement. And the stiffness measurement in this case can give us another way to assess fibrosis without doing an invasive test like the liver biopsy. Now, keep in mind the liver biopsy is still gold standard, but we do what we can to avoid this if we can get a confirmation on a non-invasive test. So Albert's FibroScan is a 6.7 kilopascals. And so that actually puts him in the low risk category for his MASLD. And so in the low risk category, our recommendations are generally that continue to monitor his FIB-4 or a FibroScan every 2 to 3 years. And then the most important recommendation is to make sure that we work with Albert on lifestyle modification, his metabolic disease management, and then a follow-up to hopefully show that his non-invasive tests have improved. So this is an important schema to tell us kind of what we're really looking for. So we've got these risk factors, the obesity or overweight, type 2 diabetes, some other metabolic dysregulations like hyperlipidemia. And so in this case, these can actually promote problems with fat in the liver. So initially we see what we call steatosis, which is essentially fat droplets in hepatocytes or fat in the liver. And then with progression, you can have steatohepatitis, which includes inflammation to that fat. So a more inflamed liver and then fatty deposits. That combination can progress to fibrosis or stiffness of the liver, and then ultimately even cirrhosis, which is obviously permanent scarring of the liver. And our overarching goal here is to reduce Albert's risk of developing hepatocellular carcinoma. So we know patients with cirrhosis have a much higher risk of developing HCC. And then the other notable things is we need to catch Albert in a place where we can maybe do something. And so if Albert has low risk fibrosis, there is a chance with lifestyle management and potentially medications that we can reverse his progression. And the same thing, if we find him in a very inflamed fatty liver state, there is also potential to reverse his situation, his status, and also reduce his risk for developing liver cancer in the future. So the risk factors we kind of talk about, and there are a few things that are out of patients' control, right? We've got some known genetic predispositions or genetic changes that can actually make it much more difficult for patients to lose weight and also lose fat in their liver. And so there will be patients that you have on medical management or diets that will have a much more difficult time losing weight. However, a lot of the things that we're dealing with in lifestyle modification are within our control. And so the focus on diet is going to be squarely focused on the reduction of saturated fats in the diet, the reduction of highly processed foods, and certainly the reduction of high fructose corn syrup that are everywhere in sweet drinks, sodas. And so those things will just progress, specifically steatosis, inflammation, and then progress on to potentially cirrhosis. There is some opportunity to use supplements, and in the case of omega fatty acids, there is some positive impact on reduction of fat in the liver. So the obesity pandemic essentially, is worldwide. We know that. And it's also something that can cause type 2 diabetes and fatty liver or MASLD, and obesity and diabetes. You can't really, with fatty liver, you can't have one without the other. So if you're not managing your type 2 diabetes and your weight, you are likely going to progress with your liver disease. If you manage your liver disease, you are most likely going to improve your metabolic dysmetabolic symptoms like syndromes like diabetes and obesity and hyperlipidemia. So again, getting optimization in your management of your diabetes, getting to an optimal weight will actually help improve the prognosis and potentially reverse the progression of your fatty liver disease. So the balance between nutrients and energy is critical in the development of MASLD and MASH. So we're always looking for a way to run an energy deficit, right? And so the simple way we describe this is, less energy in, more energy expended. But we all know it's a little bit more complicated than that. And particularly in our patients who have the phenotype of central adiposity or central obesity, this fat actually is a major promoter of insulin resistance and pro-inflammatory signaling. So it can cause worsening that inflammation just by where you carry your weight. So let's talk a little bit more about Albert here. We talked to him about his diet, and Albert explains that he eats a traditional Cuban diet consisting mostly of rice, beans, pork, corn, beef, and plantains. And so again, what we want to do is meet our patient where he is. As clinicians, the best way to have patients give you an accurate assessment of what they're eating is show no judgment and just be open to understanding what he's giving you here. So he is clear that he likes a traditional diet, which brings up the questions: how do we tailor dietary recommendations to cultural preference and food accessibility, socioeconomic status, all complex parts of how he eats. Cultural preference is deep. It's traditionally people eat certain foods and it brings them comfort and it brings the family together. And so it's associated with much more than just nutrition and also calories. And also we have plenty of difficulties accessing healthy foods in many, many, many cases. Many urban folks live in what we call food deserts, where there's just really no access to any whole foods or good quality food, and there's a lot of use by default of highly processed foods. And certainly cost is a question. Often it costs much more to buy healthy, organic, high quality foods than it is to be able to use the less expensive, highly processed foods. So again, since his diagnosis, we've pretty much confirmed is metabolic dysfunction-associated steatotic liver disease. Addressing his lifestyle, addressing his diet within his cultural preference, within his socioeconomic situation is key, because we know that the management of his diet and exercise can greatly impact not only his fatty liver, but his diabetes and his overweight. So again, lifestyle modification, dietary change, and exercise, it's always been the mainstay of MASH, and it remains the mainstay of MASH, even though we do have a new option with pharmacomanagement with resmetirom. But prior to that, lifestyle modification was mainstay, and going forward, it will be, including when we use resmetirom as an adjunct. And weight loss is directly linked to improved histologic outcomes. So if you recall at our initial slide that showed sort of the progression, we know, in fact, that 5 to 10% weight reduction of full body weight reduction can actually resolve steatosis or MASH, or exert an anti-fibrotic effects on MASH. So meaning we can move back from a fibrosis state or back from an inflamed fatty liver state, which is huge. That is really saving progression, certainly, and potentially reversing, which again will be in our hands if we can work with the lifestyle modifications. So we see certainly a lot of patients in this situation with these risk factors and with fatty liver, sort of living in this lower half of this graphic. So we've got a very highly processed, high saturated fat, high fructose corn syrup diet that just makes everything more inflamed and worse on the metabolic level as well as the liver level. And we also see a lot of sedentary behavior. And so what we recommend is trying to move closer to a better, more mobile lifestyle where patients are trying to get some aerobic exercise or at least some movement and potentially resistance training, as well as the recommended Mediterranean diet, which focuses on whole foods, fruits and vegetables, meats, that are more focused on oils that are healthy, like olive oil, avocado oil, or fish that are oily, and less on the processed products. The efficacy of diet and exercise treatment may be impacted by genetic polymorphism. Like we showed in the previous slide, we will have patients who are doing their best on these recommended diets, and it will be more difficult for them to actually lose weight or even maintain. So there are some forces sort of behind the scenes in the genetics that will make this much more difficult for a specific set of patients. So there's different theories and a couple of papers on what's the best treatment or management as far as exercise for fatty liver. There was a study in 2023 that showed that resistant training was not superior to aerobic training. And basically the simple reason for that is that it takes less energy to work on your resistance exercise than it does to do aerobic exercise. So again, one of the popular training methods, high intensity interval training, or HIIT, is not as effective. And it's not something that, if patients love doing this, they definitely should continue, because there's great improvement in smooth muscle. However, you probably want to add an aerobic component. And again, what happens in these, while you're doing these exercises, in the aerobic exercise, you're actually, as they say, burning fat, right? These fat globules in the liver will be actively sort of destroyed by lipolysis. And there's other alterations that actually give you the adipocytokines, or the cytokines involved in the adipose, actually get altered in a way that they become less inflammatory. And again, there are absolutely benefits to type 2 muscle fibers getting built up in the metabolism that will help lose fat, and also potentially reduce the effects of the metabolic diseases that we're dealing with. Again, the hardest thing to convey and to do, as anyone who's ever tried to weight knows, is basically you've got to achieve a restricted calorie intake to achieve weight loss. We do promote ketogenesis because keto diets can actually reduce hepatic fat content, and they improve insulin sensitivity and reduce some inflammation. So again, the high protein, or the Mediterranean diet recommendations are specifically recommended for those reasons. And again, there is a whole study of the genetic alterations that can cause differing responses between people to a specific diet, and that study is ongoing and poorly understood at this time. Again, the Mediterranean diet is supported by AASLD, AACE, and the European guidelines. Again, most of the professional organizations in hepatology are recommending this as a safe, healthy way to work with patients who have MASLD and MASH, and it is one of the primary lifestyle recommendations that we make. So back to Albert, he returns for a follow-up with no improvement of his labs. So this is something that's expected a lot of times, right? These are hard changes that need to be made, especially when we're trying to change a behavior. He also admits that he hasn't begun any exercise regimen, but he has been trying to cut down in soda. So how do we work with patients to create a behavior change? So again, we want to meet him where he is. So for me, the nugget here is he is at least pre-contemplative of cutting out soda. So for whatever reason, he has a motivation that maybe this would be a good idea. And so when we're working to create behavior change, we want to do some goal setting, and we want to make those goals specific. We want to make them measurable, attainable, realistic, and time-bound. So what we could do with Albert is talk to him about the quantity of soda he's currently drinking, and basically ask him, how many could you cut down in a week? And if he gives you a number, then you've got your plan. And you say, okay, when we follow up, we would like to recheck this. And hopefully he'll see some difference, and he'll, if he realizes this is attainable, then potentially he's more motivated to continue or start cutting down more. So again, the motivation's important. And in my opinion, just meeting him where he's at. We can't take everything and be super restrictive on a diet, because we all know that's not attainable. It's not realistic. At some point, if he's drinking a lot of soda, he's going to have a soda. But if we can work to motivate him to move closer to a healthier way to drink, if he can find something other than soda, maybe sparkling flavored non-caloric water would be something, or he can make his own water, or something that maybe gives him a way to make headway in this important goal that you're trying to work on with him. So there is a scale. There's multiple modalities, but particularly this exercise and diet adherence scale, also known as the EDAS, is a way to sort of check in on patients' progress, and also check in on where they're having troubles or where the biggest barriers are. So often we use a questionnaire like this at the baseline. So at your first visit, and then repeat it at an interval, 6 months, 3 months, a year. There are different criteria in this particular model that will check the amount of daily exercise and Albert's caloric intake. It's a number of questions, and what that gives you is you don't have to rely solely on the patient's recall. When you're in the office, it's hard to remember what you've had to eat today or last week. And so it will give a more objective measure of what kind of diet we're eating. And we're also get a more clearer idea of if he's having trouble with exercise. And so what the tool is supposed to do is help actually the provider recognize where he's having difficulties, and hopefully focus your attention either to the more so to the dietary management versus hopefully getting some progression with the increase in exercise. So I hope you found today's case presentation helpful, and thank you for joining me today.